In this second video on endophthalmitis, we would like to tell you about the signs and symptoms. We would like to show you different cases of endophthalmitis, post-cataract, post-traumatic, post-trab, and the endophthalmitis patients presents with severe pain, severe loss of vision, that is hand movements or worse, redness and discharge. And the signs, as you can see in these patients, the swollen eyelids, the conjunctival injection and discharge, corneal haze, hypopyon, AC full of reaction, relative afferent pupillary defect, fibrinous exudate, dense vitritis causing absent fundal glow. And to know the status of vitreous and retina, you have to perform B scan, and that B scan will tell you about the dense vitritis. You may also find vitreous in the anterior chamber, air in the anterior chamber, posterior capsular rent, aphakia or pseudophakia, and raised intraocular pressure. So these are the signs and symptoms of the patient of the endophthalmitis. The main differential is toxic anterior segment syndrome that occurs on the first post-op day. We have already discussed that most of the endophthalmitis it occurs on the second or third post-op day. So the toxic anterior segment syndrome, it occurs on the first post-op day due to contaminated irrigating fluid or viscoelastic, especially severe corneal edema, anterior chamber reaction with no pain and redness are the features of the toxic anterior segment syndrome. Intensive topical steroids and cycloplegics are given. Now here you can see the second patient. You can see dense hypopyon, the corneal haze, there is a exudate in the pupil. So the treatment in the past was based on the large study endophthalmitis vitrectomy study, which showed that if vision is better than PL positive, then you have to give intravitreal antibiotics, and if vision is PL positive, then you can go for core vitrectomy. But nowadays early and complete vitrectomy rather than the core vitrectomy is the preferred treatment option. If the clinician receiving the endophthalmitis patient is not an expert, then he should promptly refer the patient to the expert who can start intravitreal antibiotics for a day and see the response. And if the patient is not improving, then he can refer the patient to the vitreoretinal surgeon expert in doing complete vitrectomy, because complete vitrectomy can reduce the toxic materials accumulated within the vitreous that are damaging the photoreceptors, the retinal layers, as well as all the other structures inside the eye. So in a routine, if we get a patient of endophthalmitis, we start topical antibiotics, 50 mg per ml vancomycin, 50 mg per ml ceftazidime, predford, steroid drops, atropine, cycloplegics, antiglaucoma topical drops, then subconjunctival vancomycin 50 mg and 125 mg ceftazidime, then intravitreal antibiotics 2 mg in 0.1 ml vancomycin and ceftazidime same, and 0.1 ml dexamethasone. But one modification to this regime which I do is that along with the topical, subconjunctival and intravitreal medication, I also give peribulbar antibiotics and steroids 2 ml antibiotic, and 1 ml dexamethasone. So I give 3 ml peribulbar injection as well, and I have observed good results. So for pain relief you can give systemic painkillers. So the main thing is that don't wait too much. If there is not a good response to the medical therapy, go for early and complete vitrectomy. In a severe cases, you can give silicone oil tamponade as well. The signs of improvements are reduction of the hypopion, reduction of vitritis, decrease of pain, and improvement of vision. And the sequelae of the dreadful endophthalmitis are chronic uveitis, secondary fulminant glaucoma, retinal detachment, phthisis bulbi. So endophthalmitis is such a dreadful condition that if not properly managed, patient not only loses his or her vision but also loses eye. So that was all about endophthalmitis. Thank you very much.